Hi, it's Dr. Centeno, and welcome to You've Got the Power. Today we've got an interesting discussion on headaches and the vagus nerve. So, we all know about different kinds of headaches that can come from the neck, headaches that are migraine in nature, cluster headaches, etc. And there's been an increasing body of research that the vagus nerve may be involved in some types of headaches. And interestingly, stimulation of the vagus nerve may help headaches. So, since we know that there is probably a relationship between craniocervical instability and the vagus nerve, I thought this would be an interesting topic because we have a lot of patients that suffer from vagus nerve type issues. And a good number of those patients have their headaches go down when we treat their CCI. But for those who don't, is there a vagus nerve linked problem there? And is there a treatment in the vagus nerve that could help their headaches? So again, we're going to talk about the vagus nerve and its relationships to headache and some of the research out there on that treating the vagus nerve may go ahead and reduce certain kinds of headache pain. So let's get into that. First, I'm going to share my screen. As usual, I'll take questions after that. And let me share this here. So we'll put up the presentation for today, and I will get started on the presentation, and then we'll do questions after that. So today's topic is, can the vagus nerve cause headaches, or is it involved with headaches, or can treatment of the vagus nerve all by itself help certain kinds of headache problems or pain? So these are some of the references we'll be working off of today. So we know that the vagus nerve does a lot of things. And in fact, vagus in Latin means wanderer. And we know that it goes down. Oops, let me get back there. Tried to grab a pen. So we know that the vagus nerve goes down into the lungs. We know that it goes down into the heart. We know that it goes to the internal organs like the spleen, where it releases immune cells involved in healing. We know that it goes to the stomach itself and to the liver and to the intestines. So it's heavily involved in lots of different body functions. But how is the vagus nerve related to the neck? So this is just some review. I've talked about this before. Vagus or cranial nerve 10 comes out just in front of C1 and C2. So if you've got craniocervical instability, glenoaxial instability, skull base to C1 instability, you can irritate the vagus nerve, which can cause problems like tachycardia, can cause problems with GI absorption, GI motility, on and on, et cetera, et cetera. And it may even cause problems with the release of anti-inflammatory immune cells from the spleen. Now, there are some potential connection points from the vagus nerve and multiple nerves of the head. The first would be the ganglions in the brainstem, and the second is through the Alcal Plexus, where it also feeds into the sympathetic nerves, which then feed into the upper cervical facet joints, which we know can cause headache. So this is sort of a very simplified wiring diagram. In fact, if we were to make this more realistic here, this is going to be the brainstem and the upper cervical spinal cord. And there's some of these connections that look direct, but that are not direct. But I drew it this way just so everyone could understand it. So We've got the trigeminal nerves over here, and this V1 branch of the trigeminal nerve can probably lead to that ocular headache that a lot of patients with CCI get. Now, those feed into this Gasserian ganglion, and then that feeds into the trigeminal nucleus in the brainstem, and then that sends off a branch that feeds into the vagal nucleus, and then that connects to the vagus nerve, which then goes inferior to do all of those things we talked about. So there are connections between all of these things. So it is not that big a stretch to think that treating the vagus nerve, for instance, could have an impact on head or facial pain. Now realize there's also this thing that I've already done a video on called the Alcal Plexus, and that lives just in front of C2. This is C1 here, and this is C3, and then the skull would be way up here. So this Alcal Plexus is relatively newly discovered, and it contains lots and lots of inputs. So as I've already blogged on, the vagus nerve does jack into this. Now what's important is that that then jacks into the 0-1 facet joint and the C1, C2 facet joint, which we know can cause headaches. So at the end of the day, there may be connections between the vagus nerve and those joints. And these spinal nerves, the C1 spinal nerve and the C2 spinal nerve, the C2 spinal nerve we know can cause headaches as well. And then realize that the sympathetic chain also jacks in here. So we think that some types of migraine headache involve the sympathetic chain. So in looking at all of this, where does it make the most sense to access the vagus nerve for treatment? Now, one of the interesting things about the vagus nerve is that you can see it under ultrasound. So this is an ultrasound of the anterior neck here just off to the side. And this, I'm outlining it here, is a cross-section of the sternocleidomastoid muscle. Now, we know that this muscle can get pretty tight when there's a problem in the upper cervical spine, in particular at C1, C2. And look at its proximity to the vagus nerve and to, as we talk about a lot, the internal jugular vein. Now, there's very little data out there or very little discussion in the medical literature on the relationship between the SCM muscle, sternocleidomastoid muscle, and the IJV, internal jugular vein or vagus nerve, but there could be relationships there. And again, we know that this sternocleidomastoid muscle gets very, very tight in CCI patients. And so you have to ask yourself the obvious question, could the vagus nerve be getting irritated as it lives under that sternocleidomastoid? Now, we do know that there are companies out there that have produced these external vagus nerve stimulators and that have run some studies that seem to show that they can help certain types of migraine and certain types of cluster headache just through stimulation through the skin of the vagus nerve right at that sternocleidomastoid spot that I was just talking about. And we also treat this area quite frequently because in our CCI patients, we'll see this area, which is called the superficial cervical plexus, get irritated. So that then causes pain up through the lesser occipital nerve into the back of the head, kind of into the ear area and sort of the anterior neck through the transverse cervical nerve here. And this is the temporoauricular nerve. So we'll treat this area with platelet lysate higher dissection under precise ultrasound guidance in some of our CCI patients. Now, the vagus nerve is just a little bit more medial than that. So I've begun treating that vagal nerve area in some of our patients who have more convincing vagus nerve symptoms. So it'll be interesting to see how that works and whether or not that moves the needle with some of those symptoms. So there's probably multiple different ways to treat this vagus nerve. Obviously, one would be getting rid of the craniocervical instability so the upper cervical spine doesn't bang into it. The second would be stimulating the vagus nerve with an external stimulator. I do have one of those reps coming to the office this week to try that out in some of our patients to see if it moves the needle for them. And that's in particular some of our CCI patients that have more headache and vagus nerve type issues. And then the third would be treating that vagus nerve while we're treating that superficial cervical plexus with platelet lysate. So let me go to questions here. I'll stop sharing, and that's my short presentation for the day. And see what kind of questions we have. Ulysses, since the vagus nerve teaches, I'm confused. I'm not quite sure what that meant, Ulysses. Ulysses, isn't the muscle spasm cause headache in the upper cervical spine? Yes, this is really talking about a subpopulation here, Ulysses, where you treat the upper cervical spine and the headache doesn't improve. The most obvious cause in patients who have tenderness in the upper cervical spine is the upper cervical spine structures are causing the headache, whether that's joints or nerves. But this discussion is more for patients where you can't make that happen. It's been advanced by Harry Winston. Can you treat the vagus nerve, and would that be done in the neck or some other places as it goes into the body? Really, I think at the neck area, although it could theoretically be treated in a thoracic spine as well. Ricky, would vagus bother the eyes? You know, there is an oculocardiac reflex that's known between the eyes and the heart. And it was kind of strange reading about that because it has to do with a baroreceptor reflex. So what I mean by that is that if you're a deep sea diver and you get pressure on your eyeballs, it's interesting that the body registers that kind of pressure in diving, i.e. just going down and diving, to change the heart rate. So there is a connection there. Andy, if the synovial lining of the facet capsule is injured or stretched, injecting PRP inside the facet joint causes synovial lining to tighten and heal up. Yes, it can. So that's one method of trying to treat that. You know, just realize that the facet joint capsules aren't all that powerful, especially in the mid to lower cervical spine in controlling cervical motion. Even though many DMX reports talk about that, that's pretty common with anyone who has any kind of lower cervical degenerative joint disease or degenerative disc disease. They're going to get incompetent cervical facet capsules. In fact, that's one of the ways we get platelet lysate and other things around the exiting nerves. As we inject into the facet joint, and in most middle-aged to older people, C4 down to T1, that stuff will go through an incompetent medial facet joint right into the epidural space. So I know there's this talk about injecting facet capsules, which is mostly a euphemism for, I don't really know where the needle is, I just put it in that general area. And there's a talk on DMX reports of facet capsular damage, but we really don't know that that's damage because that's associated with common degenerative disc disease, which most of us will have by the time we get to be 50 or so. Regenics, been advanced by Jeffrey McGuire. Is this something that can be treated in a very anemic patient? Not sure what you're asking, what treatment you're asking about. So if you can tell me more there, that would be helpful. Ulysses, prolozone and oxygen injection. The idea behind prolozone or ozone is that you go from O2, which is normal oxygen, to O3. Now, ozone is pretty toxic, nasty stuff. So it, in the body, it seems to give up an oxygen molecule. So the idea was that you're going to oxygenate tissues. Does that happen? No one's really sure. Just realize there is no ozone generator approved for human use in the United States. There is a EMA or European approval. So if anyone's offering prolozone or ozone in the US, the generator itself isn't legal for human use. Ulysses, do low dose of PRP work all the time? Does a low dose of PRP? No. Remember, Ulysses, I think we've talked about this in the past. If you have a young patient, you don't need high doses of PRP. What I mean by young is someone, let's say, in their mid-20s. You can get away with 2 or 3x PRP, and that'll work just fine. Once we get into middle age and older, we need to up the dose of PRP. So you're going to see more failures in that age group if you start using the low dose PRP there. Andy, what happens if you eat breakfast a couple of hours before a PRP blood draw? Probably nothing in most people. What we're trying to prevent is those patients with metabolic syndrome who will have increased triglycerides and or increased blood sugar after a meal. Hence, we want them fasting. Now, that's only maybe 25 to 35% of the US population. So if you don't have a metabolic syndrome, meaning you haven't gained weight as you have aged, and you don't have high blood pressure or take blood pressure meds, and you don't have high cholesterol or triglycerides, then that probably isn't you. Andy, is injecting the capsule and exiting the C0C1 joint enough to cause a healing response in the capsule? It's a good question, Andy. No one knows the answer to that. The answer is it's probably yes. And that's what we routinely do when we're injecting that 0-1 intra-articular. Regenix, it's been advanced by DB. About 10 years ago, a doctor said he was treating my vagus nerve with some kind of weird thing that used some kind of pulses to my neck area. It was after that my out of control inflammatory problems began. What could be the relationship? I don't know what he was using to treat your vagus nerve, so that's a hard one for me to answer. Maybe some more detail on specifically what he was using, and maybe I can answer it. Grace, hi, Dr. Centeno. I had initial contact with Dr. Rosa last week. He said I have cerebellar tonsillectopia along with PANIS. Can you explain how this relates to CCI? What structures might have caused this? If it can be improved, the PICL procedure. I'm wondering if I should be concerned with CSF flow. Also wondering if you still recommend Dr. Schuster here for AO. Thank you. Yeah, so CTE is a Chiari 0. So Chiari malformation is when the back of the brainstem hangs lower than the hole at the bottom of the skull called the foramen magnum. It has to be 5 millimeters below that hole to be a Chiari 1, and then it goes from there, Chiari 2, Chiari 3, etc. Chiari 0, or CTE, means that the tonsils are right at that level of the foramen magnum. Now, by itself, CTE doesn't mean much. There's a lot of people walking around out there who have no problems, who have CTE on their imaging. However, there's some theoretical work that states that if you have CTE plus instability, that's like adding gasoline to the bonfire, because that's putting that brainstem and back of the cerebellum in a place where it can get beat up because of the instability. So by itself doesn't mean much. In combination with CCI, it means something. So the goal is still to get rid of the extra motion or CCI. The PANIS is the same thing or a little bit different. It's not a sort of an innocent bystander that makes things worse. A PANIS would be due to swelling in the bursa behind the dens. But long story short is the goal is to get rid of the instability, and because people have CTE, normal people who have no problems all the time. It's just CCI plus CTE that's the issue. So you get rid of the CCI and the CTE is not a problem again. Ulysses, putting a stimulator in the vagus nerve isn't worth it and doesn't help too. Yeah, I don't know what that means, Ulysses, or where that's coming from. Thank you, Orinoco. Alexander Christoph. Hi, Centeno, does the PICL treat the tectorial membrane? Yes, it can treat the tectorial membrane if that's suspected of issues or problems. Just did that last week. Do you recommend cervical traction? I need to know a little bit more about what's wrong with you in particular to give you some sense in general, because I can't diagnose and issue treatment orders over the internet. Just so I had some idea of how all of that fits for you, meaning what kind of problems do you have? Regenics, mid-advanced by herniated white. Do you treat chronic headaches that might have been caused by trauma from a car accident? Yes, treat that all the time. Brendan, I've been studying the pre-millennium J-shaped spine, where the cervical spine was straight. Supposedly, these people had lesser instances of neck pain. What are your thoughts on this? I don't know what you mean by the pre-millennium J-shaped spine. That may be someone's internal notations for something in particular. If you mean loss of cervical lordosis, maybe give me more information on that one so I can try to answer that better. Isabella, how does PRP from Regenics differ from regular providers who create PRP in maybe a more simplistic way? What determines the strength of PRP and what are the differences in how PRP is produced? Yeah, so Regenics generally produces much higher doses of PRP. As I was talking to Ulysses before, if you're young and 25 years old, probably doesn't make a big difference if you get sort of low dose PRP. As we get older into middle age and elderly ages, then it makes a big difference because the higher dose of the PRP, the more cellular stimulation in older patients. So if you're 25, doesn't make a difference. If you're 40, big difference. So what Regenics produces is much higher dose PRP than can generally be produced in a little bedside centrifuge used by providers. So that's sort of the big difference there. Thank you, Patty. Mark Lawrence, do CCI patients report headaches with pain behind the eye? Also internal body temperature regulation. They certainly can report headaches behind the eye, as can a lot of other problems in the neck or other areas cause headaches behind the eye. As far as problems with regulating internal body temperature, that's a less common complaint, but one I think that's out there in the CCI community. Damien, hi, Centeno, what is shockwave therapy used for? Yeah, Damien, generally shockwave therapy is used for smaller issues and problems. So for instance, things like lateral epicondylitis or an irritated tendon in the ankle, for example. So if you've got an irritated structure without much damage, then shockwave might be helpful. If you've got a more damaged structure, then you're into things like PRP and even more damage, things like bone marrow concentrate. Orinoco, could you comment on the use of Fibrin versus PRP for joint repair? I am injecting now Fibrin to the shoulder with great results. Yeah, so I think you're talking about platelet-rich fibrin, or maybe one of the products that claims to isolate more fibrinogen rather than injecting a fibrin clot. So fibrin or fibrinogen is what generates fibrin, and fibrin is what makes a clot. So you can't inject a clot because it's a clot, right? It has the consistency of dense jello. So it's not something you're going to be easily able to inject. Now, I did a blog on this one that you might be interested in. Let me see if I can find that So you can read further about this specific topic. See, about 3,000 blogs, so I can't always guarantee I can find the right one, but I will give it a shot here. So let me share that screen. So this is the blog on Regenexx.com. And if you just go to the Regenexx site and you type it in the search bar, so it's Regenexx, REGENEXX.com, 2 X's. And if you were to type in just fibrin, it'll come up. And the name of this blog is What is Platelet-Rich Fibrin Matrix, Something New or a Gimmick? So I basically go through the whole thing discussing that platelet-rich fibrin is really a gimmick more than it is reality. And the reason why it's a gimmick is that anytime you inject PRP and that PRP comes in contact with any free collagen, it's going to form a fibrin clot. And I bring up this here, which is very important, and that is the amount of transforming growth factor beta that's released from a natural fibrin clot is much, much higher than one that's artificially created in something like platelet-rich fibrin. And there's no clinical research on platelet-rich fibrin matrix being any better than PRP. So it's really more of a gimmick than it is anything else. And it's a gimmick that's used in a lot of cosmetic surgery clinics because the concept is that this will be better for facial filling. And it may be for that. But when it comes to musculoskeletal uses, it seems to be more of a gimmick than something that is the best thing since sliced bread. So anyway, go ahead and read that at your leisure. Isabella, is it bad to crack the neck after a posterior PRP, and can it cause additional damage or ruin the healing process? It's a bad habit I still have due to neck issues and happens sometimes when I have stress. I don't think it's a super bad thing. I wouldn't do it 20 or 30 times a day, but if you do it a couple times a week and it's gentle, crack, crack, it shouldn't be harmful at all. Ulysses, is it true that trigger points make the muscle worse? Trigger points are areas within the muscle that aren't functioning and are kind of locked together. So it certainly reduces the overall functioning of a muscle. Jim, just echoing off of Andy's question earlier, when PRP is being injected inside the facet joint, would the capsule already be influenced? Yes. Now, having said that, if the goal is to try to tighten the capsule, then injecting into the capsule itself might help. But again, this whole capsular thing is much more hype than reality, because a little bit like the platelet-rich fibrin, I have. Let me actually get off of this. There we go. In that, you know, when you hear that whole I'm injecting the facet capsule, it's mostly I'm putting the needle someplace. I really don't know where the hell it is. It's kind of in the vicinity of the facet capsule. I struck bone and I injected there. It might be in the facet capsule. It might be in the facet joint. It might be on the lamina, which is the bone. It could be in the tendon of the multifidus or deep stabilizer muscles. I don't have any clue. So that's really what's happening 99% of the time, not that someone is specifically targeting the facet capsule under imaging guidance. Spiros, great presentation as always. Can PRP treatments assist with restoring a nerve's myelin sheath if damaged through trauma? Yeah, it's interesting. We do have experimental research that would suggest that. And then there's also clinical research and things like carpal tunnel, where PRP seems to be much more effective than steroid injections. And that's believed to work through nerve growth factor that's released by the PRP. So the answer is we believe that that can happen in selected cases of trauma. Jim, if pressing on the muscles of the left eye of my left side of my suboccipital area causes my fingers to pass through easily, while the right side gives immediate resistance and feel hard, is this atrophy? Probably. Now, it could either be atrophy or that the muscle there is turned off. The muscle there can be turned off because of injuries in the joints there, or it could be turned off because of scoliosis, a side bend in the spine, or it could be atrophied. So any of those would be potential possibilities. Brendan, our EJ-shaped spine. Historical evidence shows the majority of people had straighter spines, especially lumbar, and had what we'd call military neck. Yeah, Brendan, it's a little bit different than the discussion, though, that we have, because we're talking about a different patient population. So let me give you an example of the logical fallacy of looking at this sort of issue in large populations. So for example, we know that if we take a bunch of 55-year-olds, men and women, let's say we take 100 off the street, we'll have about 50% of them who have degenerative disc disease in their lower to mid neck. Very, very common. Now, if we look at that point in time, maybe none of those people have neck pain, but it's probably a true statement that if we looked at that longitudinally over time, the people who had earlier onset of degenerative disc disease are going to be more likely to get neck pain in their lifetimes than someone who has none of that on their MRI, let's say by age 55. So the problem there is you're looking at a point in time study rather than a longitudinal study. When it comes to point in time studies, A might not be related to B, but if you follow those people in a longitudinal study over time, A may well be related to B. So that's the logical conundrum that you're in there. Ulysses, it's my question earlier. I meant to say when the vagus nerve causes headaches related to CCI. Not quite sure I fully understand yet, but I think the jury's still out as to whether or not the vagus nerve can cause headaches in a subset of CCI patients. Michelle, do you think that a ballistic neck twist could damage the sternoclavicular joint? Also, could slipping on one side cause damage to that joint? I don't think that the sternocleidomastoid could be yanked on hard enough to damage the sternoclavicular joint. Now, that's just my own personal view on that, and I don't think anyone's ever studied it. As far as sleeping on one side, no. I think when we see issues here, it's usually due to old trauma or long-standing this sort of posture, which is very common in our society, where there's chronic pressure on that, or scoliosis, where there's pressure on one side of the sternoclavicular joint. So I think those are much more likely to be causes. Sure, happy to help. Spiros, great presentation as always. I got that already. I feel like insurance should replace PRP with steroid injections at this point. Or maybe replace steroids with PRP. Yeah, that's probably true given the research that we have. But at the end of the day, through Regenix, we've got 1,200 companies now that cover it, including a lot of police departments. I see you've got a police shield there, and a lot of fire departments. Rhymes, hi doc, I have a really bad curve. Why do I have vibratory sense, a vibration that goes through my body while laying down? Is irritation of the vagus nerve because of cervical instability? Well, if you have a really bad curve, one thing to think about could be that the curve takes the cervical disc, and in many patients with a small spinal canal, brings that disc close to the spinal cord. So that vibration could literally be pressure on the front of the spinal cord but I would need to look at your imaging to really know. It also could be cervical instability of some type, where being in that position causes, again, something to bang into the cervical cord. Beth, why might a patient with CCI have difficulty making their hand do what they want to do, as in handwriting? So that could be due to irritation of the front part of the spinal cord. That could be due to proprioceptive issues, or it may have nothing to do with CCI. It may be a problem lower down in the cervical spine where the nerves that impact the hand are being impacted, like with a 5-6 or 6-7 disc bulge, or even tight scalenes leading to thoracic outlet syndrome. So those are some of the things to think about there. Okay, so any other questions I can answer? Happy to do so. Just to start reviewing here, we've been talking about the vagus nerve and some new treatment, more treatment-focused research that discusses that treating the vagus nerve may help in certain kinds of headaches, and what the potential connections are there between the vagus nerve and CCI, and whether or not there's a subpopulation of patients who, once you treat their upper neck, their headaches don't get better. So could those patients do well with vagus nerve treatment of some sort, whether that's a vagus nerve stimulator externally or treatment of the vagus nerve or the carotid sheath area with something like platelet lysate. Amity rehab services, when you inject C5-6 facet joints with PRP, does PRP also travel the adjacent facet disc and spinal nerves nearby? So in most older patients, the medial aspect of the lower cervical facet capsules, that would include C5-6, are incompetent. So that means that the PRP leaks out into the epidural space around the spinal nerves and around the disc itself. Now, it's not going to really do much to the disc other than maybe improve blood supply in the back of the disc, but it can help those nerves. And we take advantage of that effect pretty frequently when we treat patients who need those lower cervical nerves treated. And it's a far safer way to access the epidural space there than going transforaminal into the foramen from the side. So we do that one quite a bit and take advantage of that fact that the lower neck in middle-aged elderly people has incompetent medial facet joint capsules, so that the facet joint communicates with the epidural space in most of those patients, or almost all of them. Dennis, is it possible that many whiplash injuries also cause vision tracking problems? Absolutely. Very common thing if the upper cervical spine has been injured to see vision tracking problems or eye tracking problems. And that in of itself could cause headaches as well. So very good point there. Dennis, this was my cause through specialized vision tracking therapy. I found much relief. Yes, so very good point. What Dennis is bringing up is that the upper cervical spine is jacked into controlling the tandem use of your eyes for reading or tracking objects as they come across your visual field. So many times, if there's been injury in the upper neck, patients find relief in retraining those eyes to work together through vision therapy. Ulysses, how come C5-6 always cause hurting me this the most? I don't know what that means. Beth, can you discuss risk benefit for PICL lateral overhang of 6-7 millimeters? Yeah, so it really depends on where you are. So the risk benefit discussion is always in the context of severity of disease. So if we've got someone with extremely mild disease, then you've got to wonder, should you be doing any procedural intervention, whether it be PICL or anything else, meaning physical therapy appropriate. Now, assuming that person has failed physical therapy and maybe the disease isn't so mild, maybe the disease is causing substantial disability, Then we get into what are the options. In most of our patients' cases, the options are an upper cervical fusion, and hence the risk-benefit ratio for a PICL in that situation is extremely favorable. A tiny fraction of the complication rate of a cervical fusion, where we're looking at major complications in 10 to 20% of the patients that undergo cervical fusion. As far as lateral overhang at 6 to 7 millimeters, that's pretty much in the middle of our pack. So that doesn't even come into the conversation as being a big deal here. But it is important to understand that appropriate medical care always has to be in the context of disability for that person. And if the person is much less disabled, then you have to have an expanded discussion. I just did that with a gentleman coming from China. He had some cervical radiofrequency ablation, and unlike most of our CCI patients, it didn't make him worse, it made him better. So I had to have that expanded discussion with him because he does have overhang that they were able to measure on a fluoroscope there. And the discussion is now, if we're going to do this in you versus you just continuing RFA once a year for the rest of your life, let's talk about the risks versus benefits of someone in your situation where 90-95% of your symptoms went away after radiofrequency ablation from C3 to C5. And so that's that expanded discussion of risk-benefit that I was just talking about. What is the relative contribution of the nuchal ligament in regards to preventing forward slippage of C1? I think the nuchal ligament is a prime actor on preventing forward slippage of C1. Now, we need to talk a little bit about forward slippage of C1, how, when, why, etc. So we're talking about C1, C2, we're talking about C0, C1, because that gets a little bit more complex. And I think you said relative to the transverse ligament and facet joints. So if we're talking about C1, C2, the transverse ligament is the strongest ligament in the body. So it'd be dramatically stronger than the nuchal ligament. Now, can you tighten down the nuchal ligament and get rid of C1, C2 instability, meaning the trans or the dens coming backwards because of a loose transverse ligament? Probably not going to help the dens coming backwards. But if we're talking about, in general, motion between C1 and C2, more of a sliding type motion that's happening, then you might be able to do that through the nuchal ligament. But we're really not talking about the flexion that causes the dens to come backwards or the ADI to open. There, the nuchal ligament isn't a prime actor. So the nuchal ligament would be a prime actor in sliding type motion of C1, C2, but not in the more common issue we see, a type 1A instability, or 2A instability, where that dens comes backwards because its seatbelt is broken. And if you think about that, let's say you're the dens in a car, right? And you've got a seatbelt around your waist. You know that seatbelt is going to prevent you from flying out of the car. Now, if I were to put a piece of tape around you, let's say mat or duct tape, and I just attach that to the back seat, well, that's not going to be as powerful as the seatbelt around your waist because the seatbelt is much stronger, and the seatbelt is acting directly, holding you to the seat. So that's the transverse ligament. And the piece of duct tape is more like the nuchal ligament. So hopefully that makes some sense. Amity rehab services. How safe is anterior longitudinal injection compared to posterior injections? ALL injection ups the risk ante pretty substantially over posterior injections, because what you have here to miss is the phrenic nerve, which is the one that helps you breathe or causes you to breathe. You have to miss the internal external carotid arteries. You've got to miss the internal jugular vein. You've got to miss the vagus nerve. So all that stuff has to be missed while you're getting to the anterior longitudinal ligament and anterior disc area. So it does up the ante compared to just posterior injections where you're not worrying about any of that stuff. Certainly posterior injections from C2 down. Stacy, if my C6 avulsion is settled into my nuchal ligament, will that adversely affect the outcome of an XPICL? I'd have to take a look at those images, Stacy, to get a better idea of what it is you're talking about. I'm not quite sure about your use of the term settled into your nuchal ligament. So I think I'd need to know more there. Amity, does posterior injections help anterior longitudinal injury or anterior approach required in most cases? Yeah, so they serve different functions, right? The posterior ligaments, like supraspinous and interspinous ligament, are going to prevent the bones from moving forward, the lower cervical spinal bones from moving forward when you flex. The ALL is going to prevent a retrolisthesis, one bone moving backward on the other when you extend. So they do completely different things. Obviously, if you've got retrolisthesis, then tightening down this isn't going to help very much in the back. If you've got anterolisthesis, then tightening up the front isn't going to help that. So they do different things. But basically, those posterior ligaments stabilize the bones in flexion, and the ALL stabilizes the bones in extension. Finn, is MCAS and Prolo or PRP compatible? Similarly, would mast cell stabilizing antihistamine meds diminish success of Prolo and PRP? No one really knows if antihistamine meds will reduce the effectiveness of Prolo or PRP. I would say that probably, given that about 25% to a third of our patients who we treat for craniocervical instability have MCAS diagnosed, doesn't seem to be an issue or problem. Now, those patients are certainly going to be more sensitive to procedures. Sometimes we'll give them antihistamines during the procedure itself, meaning IV. So we certainly have to be more careful, but it's a large segment of our current patient population that gets PRP, and usually without incident. Rhymes, follow up to my early question. My C5-6 canal space is quite narrow now, and a herniated disc compresses the edge of the spinal cord. Should I get my disc injected with stem cell or any other treatments? I would need to take a look at all of that. I can't give you specific medical advice on what it is to do or not to do, but I can certainly say that I'm happy in a telemedicine to look at all of that and try to see what seems to be the most logical thing. I wouldn't start with an injection to the disc because that adds risk. I would start with an injection around the C5-6 nerves, which can be done just through the facet joint under X-ray guidance and contrast, and tightening down those 5-6 posterior ligaments because that's much, much less risky. I've got that same exact problem. I've never had my disc injected, and it's managed quite successfully staying out of the disc. So again, you need to look at the risk benefit. Injecting the disc adds more risk, and you first want to make sure that it can't be done with less risk. Jennifer, my MRI report for hip says I have mild tendinosis of the left gluteal tendons. This bothers me a lot, but also says I have a small degenerative cyst within the right acetabulum. What is that? Yeah, so Jennifer, degenerative cysts in the acetabulum are pretty common. It just means that you probably tend to bear weight on the outside of the acetabulum or the hip socket, and the wear and tear over time, you've not been able to completely repair. So since you can't completely repair the wear and tear, a small portion of the bone there has died and caused a small cyst. As far as the tendinosis in the left gluteal tendons, that's pretty easy to treat. Prolotherapy will treat that. PRP will treat that. But you need to be a little careful there because that's frequently caused by problems in the low back. So you've got to first look at the contributions from the low back if you're going to treat something like that successfully. If there's no contribution from the low back, then you can treat it locally. If there is a contribution from the low back causing that issue, then you've got to treat the back and that tendinosis at the same time. Okay, guys, I've got 2 o'clock, so we're in our last 9 minutes here. Any last questions I can get to before wrapping this up, please put them in the comments now. Just to review again, today we've been talking about the overall concept of how the vagus nerve may be related to headaches in selected patients who have CCI. In those patients, you treat the upper neck, nothing happens, doesn't work for them. Is the vagus nerve the answer in some of those patients? Any last minute questions I can answer here? Last call here for questions. We have one. Amity, my mother has RA and real bad knees. Does PRP injections help RA knees to reduce inflammation and degenerative changes? You know, there's much less data published on PRP than for RA than OA. So I've seen scattered reports, including some of our patients, of RA patients that do well with that approach. The biggest problem we see with RA patients, they tend to be on such heavy hitter biologic anti-inflammatories that there may well be some impact on the efficacy of things like PRP injections. So much less data published with some good anecdotal evidence here and there. Okay, guys, thanks so much for watching. I will be here this Friday. Have another topic for you then. And you have a great week. Thank you for all the great questions. In this show, there's no such thing as a bad question. I may not be able to understand it or what it is you're talking about, but if I can, then I'll be happy to answer it, because everyone really learns through getting their questions answered, at least in my clinical experience. So thanks so much for watching. Have a great day. And look forward to seeing you this coming Friday, same place, same channel. Or same time, same channel. Thank you.